Doctor, if you wish to start, the majority is already here, Doctor.
All right,
Thank you,
that'll
Doctor.
be good. Okay, guys and girls, Assalamualaikum, Samjatra. Welcome to a so-called revision, not really revision, something to add on to freshen your ideas of what anesthesia is all about. Anyway, we'll like I always do. It's best to address what your questions are. If you do have any other questions or anything that you want to clarify, let me know, right? And we can go as we go along. Right, I presume this session won't take too long, at the most an hour and a half or so. And the other thing is that at the end, I'll give. I understand some of you are unsure how to do a SAQ. Is it? Have you all done SAQs before? SBAQ is fine. That's easy for you. SAQs? No idea.
Doctor, some asked how many SAQs and how many SAPQs, the portions of the
Oh,
exam.
don't worry about. In terms of SAQ, it's not a matter of how many. It's a string, and they'll give you certain marks. So it depends on the scenario. It depends on each department how they put it. And in each questions, there will be some answers. Sometimes one question is one answer. One question with 4 or 5 answers, and then they total up the whole marks that will come to about between 15 to 20 marks, depends on each department lah. Okay, so it's not a number of how many questions. It will be it's called a short essay question or a structured essay question. So it depends. You take about a page or two. That's most. Okay. SBAQ for anesthesia will be only 10. Right, and if you do your minor posting, all the others will be another 10, so in total there'll be 40 of the minor postings lah, or the specialty postings. So each one with 10, 10, 10, 10. All right, and then at the end of it, you got an OSCE. So there'll be 2 OSCE stations for anesthesia. Both of them are with, you need to perform. Usually, like I told you all, the OSCE will be the ones that you have done before. That means in the skills lab or the one that you see in the hospital, theaters and stuff like that lah. Right, it's not something that's alien to you that you have never seen before, you've never encountered before. Okay, so it's just a test of how much effort you put in coming to class. Right, and if you like the summary of the test or end of posting is actually to summarize everything, make sure you have attended all the classes, and it should be, if you have attended all the class and paid some attention to it, 9 or 10 times you probably pass it. Okay, don't worry about that so much. So let's start with the questions that you posted to me. There are 14 of them. I re-summarize it a bit, put it in the PowerPoint. Let me just share it with you. Okay. Oh yeah, better take on my face. Give me a minute. I just turn on my camera so it will less bandwidth. So this is the guidelines. Let's see now. Let's see now what else. Okay. All right. Feel free to stop me anytime. All right. Hopefully it's a two-way question, two-way interaction. If I just keep on rambling, it'll be most boring for you, and probably it'll be just another class and another lecture. Wouldn't tell my. So these are the questions that you come with. Oh, actually, the one that you posted, I just show you the original. Okay, sorry, it's not there anymore. I think you all know the originals, so never mind. All right, so I've summarized it, put in a few slides so that you can sort of look at it. Okay, these were the questions posted in. Who was the one who asked about awareness under anesthesia? I just want to know how interested you are in it. Why do you ask that question? So nobody asked the question, so I can delete the question now. Nobody interested? These are the questions you ask. One is awareness. The other one is accidentally awake. And obviously the third one is what if there are activation of sympathetic nervous systems? They're all about the same. So why do you ask these sort of questions? Why do you want to know? You have encountered something like that? Does it matter to you?
Doctor, I didn't ask the questions, but I can just answer. I think we encountered it once in OT during one of the procedures.
What do you mean by how was it? What do you mean by encounter?
I mean the patient had spinal anesthesia. Actually, it wasn't like
okay. All right. Okay.
Yeah.
Okay. Then.
And the patient suddenly screamed that they're feeling pain.
Okay. All right. She felt pain lah.
Yeah.
Okay. Right. And during the procedure lah. Agree?
Yeah.
Okay. All right. So maybe I'll just put you in the proper context. When you talk about awareness, it's usually related to general anesthesia rather than regional. Regional patients awake. All right. And when, as you described, that is more of the having sensation of pain or otherwise during the regional. That means the regional was inadequate or inappropriate, most likely inadequate lah. So the doctor will either add in more medication or will convert the regional to a general anesthetic. Right. When you talk about awareness anesthesia, that means patient was asleep but aware of what's happening in the operating theater. So as I mentioned to some of you, this is relatively rare. So it actually, the worst case scenario is the patient develop a post-traumatic stress disorder lah. And they'll probably sue you and you go to court, and that's how it goes, whether there was a mishap in what you call as poor care in managing the anesthetics. Right, that one very, very rare. You haven't heard of any of that, isn't it? Have you heard any patients suing doctors for awareness? Not really, right? So it's very rare, so don't need to worry about that so much. What to do if patient actually wake up during surgery? That means there must, if you say accidentally wake up, awake, I presume that's different from awareness lah. That means you have sedated and intubated, suddenly the patient open the eyes and then probably start pulling out the tube or something like that. So that means something has gone wrong. You have not looked after your patient properly. Right, you do not allow those things happen. So depends on the surgery, depends on which phase of the surgery. Obviously, put the patient back to sleep lah. All right, then get the consequences lah. You'll be a incident report and see how it goes. Okay, the more interesting thing that you will encounter is if the patient vital signs change operatively, that means there is activation of sympathetic nervous system, or when there are stimulation of this stress response. That means patient is undergoing some stress. What does that mean? That means that, well, one, right? Usually they will feel pain. That means that's what's stressing the patient. Two, there can be a cardiorespiratory or a cerebral insult. That means patient might have got a stroke, or patient might have a heart attack, or patient might have a respiratory embarrassment or hypoxia and stuff like that. That means the patient is stressed. That means obviously you need to manage it accordingly lah. Depends on what's the possible outcome. The difficulty is trying to pinpoint which is which. If it's a hypoxia, it's quite obvious. You can see your pulse oximetry, right, and the cyanosis that you see on your patient. If you're myocardial infarction, maybe you can see it on your electrocardiogram. All right, or maybe other reasons of the cardio response or hypotension, then you can see into that. But when it comes to strokes, then you find that it's much more difficult because there's no actual indicator to decide to tell you that a patient has it. So you need to be aware of it and manage it accordingly. Okay. Any other questions about this?
Doctor, I have another question. If during general anesthesia and suddenly you can see reflexes, like maybe the patient swallows, what is the next step that usually be taken?
Right, agree. So you find that if you remember in talks of anesthesia, there are three parts: sedation, analgesia, and muscle paralysis. Okay, when you find muscle movements, if you have paralyzed the patient, that means the amount of muscle relaxant is inadequate over that time lah. Because when you give a drug, the drug will wear off. You give the muscle relaxant will wear off over time. So you need to constantly monitor it and obviously top up accordingly. If that did not occur and patients suddenly decide to move, that means you need to be careful that whether it hampers the surgery or it's just some movement that indicate the patient is off relaxant. For example, breathing effort, swallowing, or moving a finger, which you will see. Most likely, this patient will not remember it at all because the patient is sedated. The patient did move, but he will not remember it. So there will be not much problems in terms of managing. Probably the answer will be just top up the muscle relaxants, right? The other way of knowing it is if you use a peripheral neuro monitor, they want the train of 4 and all those things that will help you in deciding when to add in medication, right? But if you find that the patient is actually jumping up from your bed, that means there is gross negligence lah. You shouldn't have that happen. Okay. In terms of the other one, sedation and pain, will be your sympathetic response lah. Usually sedation, what will happen is you can get awareness if the amount of sedation is inadequate. Okay. Right. Maybe that. Anything else? Any other queries about this? No. Let's move on to the next topic. That is much more interesting, I presume. All right, here is where you are talking about management or anesthetic management. First question, what mode of anesthesia to use? All right, before intubation, is distress restless, what to do? If patient cannot intubate or difficult intubation, what to do? In case of difficulty, for example, difficulty in circulating airway, to use the laryngeal airway, spinal anesthesia. Emergency situation, if you need to operate but difficult to secure what to do. What are the indication of various modes of anesthesia, which is actually it sort of circulates around the same the similar questions in all this. That means what mode of anesthesia or what techniques will you choose for doing the procedure. All right. So like everything else, just to recap, one is in your preoperative assessment of your patient, you find that the surgeon will announce or will indicate what surgery is going to be done. And knowing the type of surgery, you will sort of estimate how long it will take and what are the positions or how the surgeon is going to do the surgery. All right. And then you will either use a regional or general anesthetic to manage this patient. So a general anesthesia allows you more flexibility. That means you can put the patient to sleep, paralyze the patient, give him adequate analgesia, and then obviously allow the surgeon to do procedure depending on where the procedure is and how to place the patient, whether sitting, lying down, prone, left side up, leg up, down. Depends on the positions where you want to assess the surgeon want to assess the patient. Right, you will have noticed, let's say a simple example, if you're going to do cranial surgery, that means you're going to open up the skull, then obviously the position of patient could be maybe just supine, it could be a little bit of head up, or maybe a long time ago, they used to do sitting. All right. If you are going to do surgery on the eye, obviously you must be supine. Okay. If you're going to do surgery on the neck, depends on which part of the neck. If the anterior of the neck, like thyroids, that will be supine. But if you're going to do the cervical spines, that means the posterior of the neck, then the patient will be in a prone position. Same thing as the chest. If you're going to do surgery on the chest, right, it can be supine, can be lateral, it can be posterior. Right, same thing as the abdomen, depends on where appropriate. If the structure is intraperitoneal, commonly it will be a supine position. If the organ is extraperitoneal or posterior to peritoneum, you may want to decide to do it prone. Same thing if you want to assess the spinal column or spinal cord, right, or the spine or the bones there, you'll be a prone position. Okay, and obviously the limbs, the abdomens and all that you have seen. Okay, so your decision will be a general anesthesia allow you to do that. Okay, the thing is, the next question is regional anesthesia. All right. All right, when you talk about regional anesthesia, as we discussed, you can have neuroaxial, that means your spinal and epidural, or you have plexus block, your brachial plexuses and your what do you call it? The lower limb plexus, what is it called?
The femoral.
There's femoral. The plexus.
Lumbar plexus, lumbosacral. Is it the lumbosacral plexus?
Okay, right. Or if you want to do, then you need to also know that when you do plexuses block or individual nerve blocks, you need to know the distribution of the nerves. That means the sensory distribution, and sometimes the muscular or motor distribution, and the extent of the surgery that the surgeons want to do. Commonly, when they do surgery in the limbs, they may end with a tourniquet. That means you need to know where the tourniquet is going to be put on and how to manage it. All right. So when you come to regional, you'll be more thinking and more things to discuss. And regional always related with local anesthetics and how much you can give and whether you want to use a catheter to prolong the block. All right. So in a nutshell, if you have a choice, I will do a regional, basically because it is safer as the patient is most likely awake. That means I do not need to mess around with the cardiorespiratory system that much, especially the airway and intubation and stuff like that. Okay, and patient being awake, patient can tell you if your patient is in pain or some other discomfort, maybe have a chest pain or maybe patient stroke, also you will know, right? That means a regional will be a better choice. If you can't, then a general anesthesia. So to answer all these questions here, you find that's how you will assess it. So what happens if you have a difficult intubation? Obviously, first choice is regional lah. Right? If you cannot do regional but need to do a general anesthetic, then you need to secure the airway. So now you have to start thinking how to secure the airway. Laryngeal mask airway is a choice, but you may lose control. That means you want to be more sure that you need to intubate the patient. Now, the intubation of this sort of difficult airway, you need a little bit more technique. That means you can either keep the patient awake and intubate him while he's still breathing. That means either using a fiber scope or fiber optic scope, or you may just use it blindly. Or if you want, you may want to consider a tracheostomy so that you can assess the airway and then have the surgery. Right. These are more advanced things that the anesthetist will do lah. So basically, as a house officer, medical officers, usually you will not need to how you call it, manage this sort of patients. Okay, so like patients who are obese, head injured, and all those things, all you need to put it in that context. What are the extent of the technique that you're going to use? Because if you notice for your exams, I'm definitely not going to ask you questions whereby it's a postgraduate question about technical ability or how to manage all these sort of difficult cases. What we want you all to realize is, yes, there is general anesthesia, what's advantages, disadvantages, and how to go about it. Okay. So before intubation, if patient is distressed and restless, obviously you need to do something. Why is the patient distressed? Is it because fear, pain, or actually having an actual respiratory embarrassment or respiratory distress? Right? So you need to consider all this. And restlessness, especially when you talk about little children where they cannot cooperate with you, they be screaming in the breathing theater, you need some technique to manage this sort of patients. So these are all things that you will see or you have seen, all right? You will encounter as you go along in your medical practice. But technically, all this you don't really need to go in the depth into each of these. Okay, in emergency situation where urgent to operate, difficult to scale away, you may end up with a tracheostomy and have the surgery done. For example, a patient comes to you and have something stuck in the throat and causing him to be nearly sinus and having stridor loss, right? So you find that you need to have surgery quickly. Okay, so what to do? Do a local anesthetic, tracheostomy. Once you have secured the airway, put the patient to sleep, then have the surgery to remove the foreign body or stuff like that. Okay. Right. And the last question here regarding your anesthesia spinal epidural. It can be used for anything and everything that you need to do, especially below the level of your blockade. That means your spinal epidural. Let's say you do a maybe if you talk about a low thoracic epidural, that means that you block from maybe T10, T8 downwards. Then you can do surgery anywhere in the upper abdomen down to your toe, your choice. No problems. Okay, knee replacement, femoral block, and all those things. These are all technique. the idea is, as you realize, you know the anatomy, you know the drugs that you can use. So if you can manage all of them, then you should be all right. Okay. So any expansion from these questions in terms of anesthesia, modes, techniques, know-how? So in a nutshell, regional first, general anesthesia second. Right. So,
Prof, so
yes.
for the I read somewhere about the maneuvers. They use cricoid and the cricoid pressure and the
Yes.
burp technique. Do you still use that in?
Cricoid pressures are usually these. That technique is used, especially for what I call as rapid induction. Okay, these are done especially in patient in emergency situation whereby we consider them. The term we use is called full stomach. That means their stomach is not empty from fasting. Even though you have fasted several hours after the emergency, I mean, let's say a patient have a trauma, let's say abdominal trauma, and you need to do surgery. Even though you have fasted several hours, 6, 8, 10 hours, the thing is because of the trauma, the assumption is the GI is non-functional. The stomach could be still quite full. So they will do a cricoid pressure during the attempt to intubate. All right. Okay, it's just to prevent aspiration. Anything else?
Doctor, for like upper parts of the body, for example, the breast or the thyroid, so for those cases, what kind of anesthesia do they usually deliver?
Okay, the easy answer is general anesthesia lah. The more difficult answer is you can actually block individual nerves so that you can do surgery, even the breast or thyroid or even your larynx, your tracheostomy, your what else? Yeah, and even in the neck, right? Lumps in the neck, brachial cysts and all that. You can block actually individual nerve supply to that area and have the surgery done. Technically more difficult. That's why a lot of time we end up with a general anesthetic for those sort of cases. That's why if you go to operating theatre, commonly they will do a general anesthesia for the upper abdomen, chest, and head and neck surgery. Whereas with the lower abdomen and limbs, pelvis, lower limbs, all, and sometimes the both upper limbs, you can do a regional block because technically much more simpler compared to the upper regional block. Okay, that's the flow of the things that people do. But in some centers which are very good at regional anesthesia, right, they can block anywhere in your body and have it done in surgery. You may also want to consider, this is out of the blue lah, acupuncture for surgery. Does it work? You may want to Google up acupuncture for brain surgery. Then you may see that it actually works. Okay, any other questions? Anything else? Any other queries?
So, doctor, in cases where general anesthesia cannot be performed, for example, in the thyroid or the breast, so basically the upper abdomen, then they'll opt for the other option, right? Of individual.
Yes. Sometimes, let's say if the patient has got, for example, a patient has got renal failure, which is very bad, and has got arrhythmias. Together with that, the patient has got some amount of heart failure. and he needs to have the parathyroid removed. So we can actually do individual nerve blocks to the neck, and then have the surgery done. But then obviously this patient must be very cooperative. You don't want the patient to move about. Same thing like your cataract surgery. Imagine you do that cataract surgery, right? Commonly you see now is local anesthetic, isn't it? Imagine the patient is not cooperative. No way the surgeon can do the local anesthetic. So you may end up with a general anesthesia. If the patient has got a high risk because of comorbidities, then the regional anesthesia will be attempted first rather than the GA. Okay, that's how we think about patient. That means safety and patient well-being is utmost important, and we use techniques, regional and GA or combination, to help have the surgery done. Okay.
So, doctor, for general anesthesia, is there any absolute contraindication? Like, is it that patients which are ASA 3 or 4,
No.
patients like that?
All right. Let's put it this way to you. If you talk about any procedure, there's no absolute contraindication for any procedure that cannot be managed. So somehow the anesthetist will be able to manage whether this patient, even the patient is very, very ill and brink of dying, you can still do surgery. There must be a method of doing it. But like saying, the risk is relatively high. The risk is always death. That means if things don't go according to plan, or you find that you cannot manage, or there is some mishap during the procedure, then the patient may die from the anesthesia and surgery. So that's the risk that you need to take. That's why, for example, let's say the patient just had a myocardial infarction, and you need to do surgery for the, let's say the patient has got acute appendicitis. They came in, let's say this patient, for example, this, let's say 55-year-old man came in with acute chest pain. You diagnose as a inferior MI, all right? While in the ward, after 1 hour, the patient developed right iliac fossa pain, and you diagnose as acute appendicitis. So what's the management? Surgery? Normally, yes. Sometimes you will try not to do surgery, right? Because he has just had a myocardial infarct. If you challenge him, that means you stress him some more with your anesthesia and surgery, he may go into heart failure or have another myocardial infarct, and he may die from a cardiac arrest. Okay, that means it's high risk. So you will want to consider not doing surgery for the acute appendicitis. But let's say if this is the appendicitis is acute peritonitis, the patient developed the appendix burst, and it caused peritonitis. Then you need to do surgery to remove the I wouldn't say abscess, the appendiceal stump, and also clean up the abdomen, or else the patient will die of septicemia. So now you have not many choices. So this patient will need to have surgery, and you need to manage the myocardial infarction. So he'll go into a category of ASA maybe 4, whereby he is actually very high risk of dying. The chance of him dying may go up to as much as 30 to 40%. Right? But you still need to do surgery. So then you may want to consider a general anesthesia or a regional anesthesia. That depends on the expertise of the surgeons and the anesthetists. Okay, so in truth, there's no contraindication of general anesthesia for any procedure. Maybe I may put a question to you. Why are patients going for organ donation? Patient is brain dead. Do you need anesthesia? What do you think? Do you need anesthesia or patient who's brain dead? Going for as a donor for organ donation, that means you are going to donate the heart and the lungs.
No, doctor, because they're dead.
All right. Technically, no, but humanly, we do. That means we put the patient on a ventilator and we use some gases or either desperine or sevoflurane and put assumption is gives a amount, maybe 1 or 2 meg, and maintain all the cardiorespiratory parameters and have the surgery done. So after the surgery, after they remove the heart and lung, what happened? Now the patient, you are on the endotracheal tube, no more lung. What to do? What do you think? You are the house officer. You just came in for organ donation. That means you're in the transplant. You are in the donor section, whereby you're going to assist the surgeon. The surgeon is going to remove the heart and lung from this patient on the table. We have endotracheal fluid in place. The ECG, everything shows sinus rhythm, BP about 110 systolic, right? Pulse oximeter showing about 95, 98% on the ventilator, and we'll start off some desperine. So now you do surgery. So you'll probably remove the lung first or the heart first. Which will you remove first?
Lung first.
Lung first. Why?
Because you need the heart to maintain the vitality of the other organs to pump blood.
You don't need the other organs. You do need other. If you remove the lung, where is the blood going to go?
I think you remove the heart first because the lung is still being ventilated. So at least once you remove the lung.
Okay, if the lung is ventilated, there's no blood going there. What for? Interesting, yeah? If you are the surgeon, what should you remove from heart or lung? How to answer a question like that? Any guess? You all think about the lungs. Now, what is it? What crosses your mind when you talk about organ donation? You want to remove the heart and lung. Lungs, both lungs, sorry. And obviously they take out the liver also lah. And the kidneys. The kidneys and liver, they remove first. Okay, that one you don't need when the question arises, the heart and lung. Which one you want to remove first? Heart or lung? What do you think? All right. The first question you ask is, where is the recipient? You have a donor in your theater, but where is the recipient? Is the recipient beside in the same hospital or different hospital? Especially the heart. Seldom in the same hospital, commonly different hospital. So let's say if it's a different hospital, we'll remove the heart, quickly put in the eyes and transport it, use police escort. And then if you need to fly, you need to have a chartered flight ready to fly on the dot and then deliver the heart to the other side. The other hospital, they will need to know once you have removed the heart, they need to start surgery in the other patient to prepare for the heart to arrive and re-implant. So the lungs can be a bit later, basically because the heart needs, it is a higher oxygen consuming organ. So it needs time is a very important factor in the viability of the heart. Lungs can be a bit later. So we'll remove the heart first, then remove the lung. Then now you got a patient without heart, without lung, liver, kidneys, and whatever, anything else you want to remove. So now what? Do you still ventilate the patient? Obviously not. There's no more lungs in it. All right. Do you still give IV sedation? You don't really need. Okay. So consider that this patient is a. We'll just close up the patient and send the patient to mortuary and deliver to the family. Okay. Something different lah. All right. Any questions else here regarding the what do you call this technique or mode of anesthesia? How to approach patient? Commonly, to make life for yours, simply either GA or regional. Always regional first, GA second. If it's a lower limb, lower abdomen, always consider regional anesthesia. You can use GA, but commonly regional anesthesia lah. Right? If upper abdomen, chest, head and neck, then GA will be a better choice, easier choice lah. Okay. Technicalities, obesity, head injury, neck injury, difficult airway, history on difficult intubation and all those things, then you find that you need different techniques. So that one, leave it to the specialist to decide how to go about it. There are many ways of doing. Even like I mentioned to you all, some of you, during COVID, how do you want to intubate patient? They need special devices. You must gown up. You must have something that protect the patient such that when you intubate, the patient don't cough on you. Okay. Right. Anything else?
Doctor, why don't you do general anesthesia with laryngeal mask airway?
Why? Then you when or why? Okay,
When?
I answer to you when and why. Why is that? So that you usually a laryngeal mask airway is less invasive compared to the endotracheal intubation. That means you easier to insert, and then you find that there's less trauma to the trachea. There's less chance of tracheal trauma, hoarseness, maybe stenosis and stuff like that. The only bad part about laryngeal mask airway is it doesn't prevent aspiration, and it is device that you need to be careful on lah. Endotracheal tube intubation needs more technical ability, and you will insert it. And more so, if you want to paralyze the patient, you find that you use the endotracheal tube allows you to control the breathing better compared to laryngeal mask airway. Though laryngeal mask airway you can use with a paralyzed patient or not paralyzed patient. Patient breathe easier on the laryngeal mask airway compared to the endotracheal tube if they are not paralyzed. So when to use a laryngeal mask airway? Obviously, if you do not need paralysis, that in surgery, for example, you want to do breast surgery or surface surgery, your lumps in the upper abdomen or chest walls, right? Then you find that laryngeal mask airway is quite adequate. If you want to do a something like ear toileting, foreign body in the ears, right? Then the laryngeal mask airway should be quite adequate, right? If you want to more stimulating, then the endotracheal tube would be much better. That means if you want to do a thoracic surgery, then the endotracheal tube would be better than a laryngeal mask airway. Or you want to do a thyroid surgery. Some people do thyroid surgery with laryngeal mask airway, but much more hazardous compared to the endotracheal tube. Okay, so the decision, no need to worry so much lah. We will not make you, we will not question you on this, basically because these are decision making that you need in-depth knowledge of anesthesia. Okay.
Okay.
All right. Anything else? Go on to the next slide. Can I? Okay. This is pre-operative and post-operative care. All right. If a patient has underlying disease, hypertension, diabetes, bleeding, then we stop the medication prior surgery or can we maintain them? Okay. When you assess the patient pre-operatively and you notice or you have certain that this patient has a pre-morbid condition or medical condition, then you have to decide what to do. Commonly, we want that pre-morbid condition to be in control. That means you don't want it to be healed, but you want it to be in control, something that is manageable. Like diabetes means in control. That means the sugars are in the normal range, hypertension in the normal range, and stuff like that. Even bleeding tendencies need to be managed such that the patient don't bleed. Okay. And then whether you stop or maintain medication depends on the type of medications, whether this will impact, for example, a diabetic medication. If it's short acting, for example, all the insulins, then you may want to consider to maintain it or stop it, doesn't matter because you can add on as you go along. But if it's a long acting medication, right, for diabetics, maybe you want to stop it because if it's what happens is these patients are usually fasted intraoperatively and maybe sometime post-operatively, and the anti-diabetic medication may impact and cause hypoglycemia, right? For hypertension, commonly we will ask the patient to continue the medication and we will manage the patient accordingly, all right? Bleeding tendency and so on. Let me just show you some some write-up on sorry, this is passing. All right, you find that in this is a Ministry of Health document, right? If you're really interested in anesthesia, they wrote a lot of things on this. It will tell you how to manage diabetic patient assessment, what to do, what's the range, and all the stuff, right? If this fasting random and all this, how to come about it lah, what to risk and everything. There are a big protocol on that. I skip this a bit. Then even you've got, next one will be, right, obstructive sleep apnea, hypertension, everything will be there. So there are a lot of guides on this if you're really interested. But basically, you want the patient between a normal range and you know that whatever illness they have, you can manage it, right? Thyroid disorder, whether you should continue medication, stop medication, all right? You need to know the T4 levels and stuff like that. Okay, now. So you find that there are a lot of guys. Sorry, a lot of guides in this lah, right? So let me just show you the airway difficult management. There is a lot of stuff here. You really interested. My suggestion to you is you do this after you finish your exams lah, when you got time. Okay. Here's something on intraoperative awareness and brain function monitoring. Right. All you need to do is just read it. Okay. And this is sorry, the fasting guideline and daycare. Okay, that's another. All right. So you find that there are a lot of all these things. If you're really interested in the how to manage all these patients. Basically, as house officer, what you do is make sure you have documented all these illnesses prior to surgery. Make sure they are in control. Right? If they are not in control, control it first, then only subject the patient to surgery. The main reason is because with good control, the risk in surgery is less compared to bad control. That means ASA 3 or ASA 2. Okay. I've shown you the statistics that, you know, the ASA 3, the mortality either doubles or triples compared, depends on your illnesses. Okay. Right. So obviously whether you maintain the medication or not depends. Right. Regarding fasting guidelines, adults and children is quite straightforward. What we have is actually see now, where's the fasting guideline? Fasting guideline, sorry. Yeah. All right. February Vice is really an old document, more than 15 years old. So what they do is quite simply this one. All right, adults, any food, 6 hours or more, clear fluids up to 2 hours to surgery. Our biggest issue always not knowing when the surgery starts. If the surgery is at 8 in the morning, then it's easiest. But if a patient is scheduled as a second or a third case, you find that it become more difficult. For example, what call that? If two patients going for thyroid surgery, the first patient is at 8 in the morning, the next patient, it depends. It can be at 9, 10, maybe 11, depends on how fast or how difficult the surgeon does the surgery. So you find that 2 hours prior to surgery is not easy to come by. Okay, so usually we use a 6-hour rule. That means overnight fast from 12 midnight. Usually people don't eat at 3 a.m. in the morning lah. Right, so after about midnight, patients have gone to bed, then you find that you will just don't need to feed the patient. Children is slightly different because if your children are very small, they're on breastfeeding, they'll need, sometimes they are breastfed even up to about 4, 5 o'clock in the morning. So if the surgery is at 8, then it should be about 4 in the morning, then you have the last feed. Okay. So this is the simple guidelines, the rule. Okay. So we find that the bottom here, right? 2, 4, and 6 rule. All right. So 2 hours clear fluids, breast milk, and food. All right. Clear fluids include water, glucose drink, Ribena, cordial drinks, clear fruit juices, black tea. That means you are talking about there's no any particulate matter in the fluids. All right. That means you don't have fresh oranges, freshly ground oranges, then you don't, and then they are talking about no coffee, right? Black tea they allow here. Sometimes we also don't encourage tea at all. Okay. All right. Discharge criteria for daycare patient. Discharge criteria, where is it? Where does it? Where did it put it? Okay, daycare. All right, sorry. So you find that they have what we call as a PADSS, Modified Post-Anesthetic Discharge Scoring System. same vital sign, activity, nausea, pain. They give a scoring system, bleeding, total. All right. Then on discharge, you find that they must have a score of more than 9. That means they score, right? Then they give you a checklist whereby you can look through it, whether you have given medication and stuff like that. So in a nutshell, when you talk about discharge of patients who are in daycare surgery, they must have the PAT score more than 9. All right, and then commonly you want to see that this patient has got good pain control. And then this patient, when they discharge, they are not allowed to drive home. That means there must be someone accompanying the patient. And most importantly, when the patient is at home, right, you find that there is someone responsible with the patient at least 24 hours after discharge. That means a person, an adult supervising this patient for a day. Okay. Okay, so these are all things. Have any problem? These are all the surveys lah. So this is also under the KKM hospitals punya guideline. Okay. All right. That's in a nutshell anesthesia. Do I have anything more? All right. Any questions here on pre-operative and post-operative? Pain management, we have talked about it already. All right, make sure you get good pain management for this patient. Right, you need to review them, and if they got good pain, if their pain score is high, then it needs to be treated. Any questions here? Yes.
For
Sorry.
cases that cannot be managed, for example, like a patient presents to you and the patient is like very obese, so like it's quite severe.
Okay.
Do you tell them if it's not like an urgent surgery, like it's not very, and do you tell them you just come first lose weight and then come back, or like you proceed?
Okay, so there, in this case, then there must be a discussion. When you talk about urgency of surgery, excuse me, urgency of surgery, it depends on the surgeon, how urgent they want the surgery done. Like you pointed out correctly, all right, a patient who is obese obviously has got a lot of morbidities and a lot of risks. If it's coming in for, let's say, a simple surgery, let's say a breast lump, all right, how long can you wait before you have the surgery? Probably it can be months to years, isn't it? Low breast lump, there's chance of being cancer. Okay, let's say the much simpler one. You got a lipoma in the back. A huge lipoma measuring about maybe 8 centimeters in size on the back of his right scapula. He wants to have surgery done for his lipoma. You know what's a lipoma, I presume? Yes, no? Okay.
Yes,
so,
doctor.
All right. So it's an elective, simple surgery and really no hurry. So you can consider that speak to the surgeon, talk to the patient, and assess the risk. What's the chance of the lipoma being cancerous? Very, very, very low, isn't it? Turning cancerous, very, 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 very low. So you find that you can leave the lipoma for another 10, 20 years and then it will not cause any problems. So now the problem now is this obesity, right? Would you want to manage the obesity? Yes, you make sure that the obesity is reduced for this patient general health. Otherwise, you may want to defer surgery for a prolonged period. Right? Yes, right. As you correctly pointed out, that's what you should be doing. Okay, there's no need to do surgery or things that are not worthwhile, the risk, not worth the risk lah. Okay, but if you find that this patient needs surgery, for example, this patient is obese and he has got a ruptured ectopic pregnancy, do you need to do surgery now? Yes. So you will manage the obesity, difficult airway, obstructive sleep apnea, hypertension, diabetic, whatever have you, you need to manage it and have the surgery done now. Okay? So the bottom line is simply if you have your friends and your relatives all, make sure they are not obese. If they are, better start now, reduce it. Same thing as smoking. No point start smoking now. Okay? Anything else?
Doctor?
Hmm.
I have two questions. First,
Yes.
if we have like emergency surgery and patient has diabetes and hypertension, so we can simply manage them intraoperatively, right?
Okay.
And then second
Yes.
question, is there any sign to start enteral feeding after surgery?
Enteral feeding. Okay. Right. So first question, if the patient, you have to distinguish between emergent and non or elective surgery lah. Whenever you talk about elective surgery, that means the surgery can wait overnight, 2 days, 3 days, 5 days. Then you find that you will try to manage whatever deranged metabolic function the patient has, hypertension, diabetes, renal failure, whatever have you. Right? Get that into normality, then only subject them to surgery basically because you want to decrease the risk for this patient. Right. If the patient cannot wait, that means the surgery need to be done now. For example, a ruptured ectopic pregnancy or bleeding diastasis, something that will kill the patient within the next couple of hours. Then you will manage whatever poor health this patient has to the best of your ability so that the surgery can carry on. Yes, you will manage diabetes, hypertension intraoperatively. If a BP is too high, you still have to manage it. But obviously, the risk for the patient is relatively higher. Okay, may I suggest to you, try not to use the word simply, because if you talk to the patient will jump up and down. Nothing simple about it. Okay, never mind. The next question is that you say, what about enteral feeding, post-operative feeding? Okay, that is actually the realm of the surgeon when they should start feeding this patient. Especially if you have surgery that involves the GI tract. That means some surgeons encourage feeding early. That means within the next day or day after, even if they have bowel surgery. Some surgeons say wait a few days. If you have to wait a few days, you may want to consider parenteral nutrition. Right? That actually meant, for example, a patient who has got a colon tumor. I've been having the tumor for the past maybe 3 to 5 months, and he has lost maybe about 20 kilos from his tumor. Then you find that this patient needs to be fed very quickly because the patient has lost lots of weight. Okay, then you need to involve the dietitian and how to start feeding this patient. And remember, there was such thing as called refeeding syndrome, right? So you find that you need to be gentle with them, but you need to feed them early. Then you may want to consider parenteral nutrition rather enteral when you start off the surgery after the surgery. Okay, some surgeons are comfortable starting enteral surgery after GI surgery. Some are not, depends on the surgeon. Okay, but the bottom line is, should you feed? Yes. How soon? As soon as you can. How long can you delay? If the patient is otherwise relatively healthy, that means a day or two shouldn't be a problem. But if the patient has lost weight, then you must start it soon. That means within a day or less. Okay?
Okay, doctor, thank you.
Okay. And anything else?
Doctor, what are the benefits of enteral feeding over parenteral?
And okay, basically the enteral will be simpler, easier, cheaper. Parental is more complicated. The biggest issue you have is infection. You get a septicemia. Not to say about depends on the the feed or nutritional feeds that you give, they may have, they may not be able to manage it. That means you can have hyperlipidemia problem, hyperglycemia, hypoglycemia problems, and stuff like that. Right, and also actually electrolyte imbalances from your parental nutrition. Whereas when you give enteral, commonly because enteral is like a normal feed, your body will take care and try to absorb what is required and not absorb what is not required. Whereas in parenteral, the body has no choice but to receive everything that you give, and you may not be able to give the appropriate amount because of your calculation or your know-how. Okay, but the biggest problem you can see is obviously is infection. Right, enteral, the chance of infection is very, very low, whereas parental, the infection rate is high. Okay, and high means you may end up with a septicemia. Patient die of septicemia rather than die of starvation. Okay.
Thank you, doctor.
Anything else, or we move on to the last slide? Okay, CPR. Where BP is low, should we opt for IV saline or inotropes? Okay. Do you remember your Starling curve? You may not consider CPR anything lah. When you talk about cardiorespiratory, cardio resuscitation, when a patient is hypotensive, remember your Starling curve or not? Do you know how to plot a Starling curve? Dr. Fauzia, take your how to plot a Starling curve. That means you want to know what is the cardiac ability of that patient, that specific patient in front of you. Do you know that? How to do it? Any guess? What do you do? Anyone? Do you all come across a term called fluid challenge?
No, doctor.
No, never heard of. Fluid challenge. You want to Google up what fluid challenge is? Let me just find out, see what it says here. See the first here? The principle behind the fluid challenge technique is that by giving a small amount or a small amount of fluid in a short period of time, the clinician can assess whether the patient has a preload reserve that can be used to increase the stroke volume with further fluids. Right? Let's have a look at the Starling curve. Okay, tell me challenge you. Senior. Does it increase the size? Nope, sorry. Okay, if you look at this curve on the right, okay, remember all this curve, right? If you have a patient who has got a ventricular performance or output of this rate, let's say here, right? You find that if you increase the stretch, to increase the stretch, you run a amount of fluid, maybe between 3 to 400 mils, quickly in an adult patient. Then you find that if the patient's cardiac output performance improve, that means either you can measure the cardiac output, BP, pulse, and stuff like that. That means the patient's on the left-hand side of the starting curve. That means you can keep on increasing it. The BP is low, you can keep on increasing the fluid. But if you give fluids and the patients like this one is already over stretch, then you find that the BP will not improve or the cardiac output will actually deteriorate. That means the patient on the right-hand side of the curve. That means the patient cannot give fluid anymore. He is optimally fluid filled. That means the amount of fluid that is in the body is really optimal. You cannot increase it anymore. Okay, so you will challenge with fluid first. What happens when you give inotropes? Inotropes is something like moving from this curve to that curve to that curve. That's what you do. So to answer your question, whether you stop for IV saline inotropes, always start with fluid first, so that you know what is your you find that if your heart is optimally filled with fluid, then you find it has got the best performance. Then if that best is not good enough, the PV is still low, then only you start your inotropes. Okay. So when you do cardio resuscitation, that's what you do, right? If you have that means the patient has got blood pressure already lah. But let's say if you do a CPR in a hospital setting, once the patient had a cardiac arrest, that means asystole, right? You have done your CPR and the patient has two things can happen. One is patient that means did not revive. That means the patient died. That means obviously the next step is sent to the mortuary lah, right? If the patient has revived, that means you have got blood pressure up, the pulse is up, right? The ventilation is good, patient is pink. Then the next thing you will assess is his mental status. What is his mental status? That means if he is conscious and looking at you, that means he probably did not suffer any much cerebral insult. Then you may want to just watch him and monitor him further lah with your ECG and blood pressure and stuff like that. But if he has got some mental insult, that means there is some cerebral hypoxia, the patient may be drowsy, then you may want to consider to keep the patient left lateral, and you find that you suspect that this patient has got a lot of cerebral hypoxia, the brain will start to swell up, then you will manage this patient with intubation and consider a cerebral resuscitation as you were done in the patient with the CNS head trauma. Okay, so that's what what you do in a hospital setting. Okay, and allow the patient to come back to wake up later on, maybe a day or two. Okay, and assess how much cerebral damage there is from your cardiac arrest. Okay, make sense? Okay or not? Any other questions related to anesthesia or otherwise? Anything that you are uncomfortable with, you're not sure of? You ask me about what's going to come out in the exams, everything that they have done before. No need to worry. The SPAQ, there are so many questions, so they'll ask you everything. The SAQ will be like you will see, in a scenario base. Right, and the OSCE, obviously, those that you've done in your what call it, skills lab and what you see in the operating theatre. Anything else?
Doctor, I
Hmm.
have a question. So if let's say a patient, we have a patient that is a heavy smoker,
Mm-hmm.
have a congested oropharynx, so
Mm-hmm.
injected oropharynx. So
Hmm.
in that case, like, is it safe to give GA, or
Mm-hmm.
is it
Okay.
okay to give I mean, is it okay to intubate the patient? And
Okay.
also, like, yeah, what is the management we can do for this patient?
All right. So now you have a patient that has got whether you got the upper respiratory tract infection or not. Right. You have to decide if the patient is having an active upper respiratory tract infection. Right. If you're going to end up intubating the patient, then you may introduce the upper respiratory tract infection to a lower respiratory tract infection because you're endotracheal tube. So that was what you would not want to do. You may want to consider postpone the case, or if you need to do the case, maybe you want to do a regional. If you cannot do a regional, then you need to intubate also. Then you intubate and obviously hope for the best lah. And there's a higher chance that the patient end up with a pneumonia. Then you need to manage the pneumonia. Okay, so the bottom line is, well, as it goes along. Because it depends on how urgent the surgery is, okay? If the patient has got a very urgent surgery, the patient has going for the cardiac bypass, must do to now, then no much choice you need to do lah. Agree?
Yes, doctor. So
Okay.
if can we like suggest laryngeal mask for this patient?
If you can manage with a laryngeal mask, then you find that there's less chance of lower thoracic tract infection. But if you're going for cardiac surgery, you think your laryngeal mask is going to help you? Not really, isn't it? You're going to open up the chest, right? So you find that it's not going to be quite feasible. It depends on the surgery and depends on how urgent it is. All right. Like I said, don't need to worry so much about this sort of questions, basically because first and foremost, your exams won't be asking you questions like that. Secondly, this as you are a house officer or medical officer, that will be taken care of by the anesthetic department. Okay. Just
Doctor,
mm,
she mentioned the patient is also smoking. So
yeah.
prior to surgery, do you advise the patient stop smoking, or
Yes, if you can manage to stop smoking, if you read some of the papers, they suggest if you want to stop smoking, you must stop at least 2 weeks prior to the surgery. If you're going to stop overnight, forget about it. Smoke, don't smoke, doesn't make any difference. Why 2 weeks? Well, you need to recover all your ciliary function, right? Remember, your smoke will destroy your ciliary function, right? And then also your smoke also will poison your hemoglobin. You get a lot of carboxy hemoglobin. So carbon monoxide also, all right, the carbon monoxide also, right? So this thing has to be regenerated and purified. So it takes about 2 weeks to get those things up and running, decrease your phlegm production and stuff like that. But if it's going to be overnight, makes no difference lah. Manage it accordingly lah. Because it's going to help his respiratory function. Okay. There are some cardiac surgeons who refuse to operate on patient who smokes. If you're going to smoke, you know smoking is associated with myocardial infarction, ischemic heart disease. If you're going to smoke, the surgeon said, I'm not going to operate on you. You either better stop smoking before you have surgery. That means for life, stop smoking. Because if you after cardiac surgery smoke again, the chance of you get another ischemic heart attack is very, very high in the region. I mean, you'll probably, what we call it, your graft or the cardiac surgery won't last as long. Any of you know one good example? You know our previous Prime Minister, which one you know not?
Is it Dr. Mahathir?
When he had surgery for his heart? In the 80s, right? And how old is he now? So but you look at him, does he smoke? You look at his diet, you find that you need to look after all those things to prevent another heart attack. Okay. Okay, anything else?
For reversal of muscle paralysis,
Yes.
how frequent is it like fully reversed by the end of the surgery? Like, is it common to have cases where the patient is in the post-operative phase and they're still undergoing muscle paralysis?
There is a chance. That means if you are not careful, not properly done, there is a chance that your muscle paralysis is inadequately. Okay, so it does happen, very uncommon, but you have to be careful lah, technically. That means that's why when you give a reversal, you must check whether the patient is breathing adequately before you extubate the patient. Okay, it does. I mean, these are all like I always tell you all, whenever you do a certain therapy, you must look for the effectiveness of that therapy. If you don't, you end up in trouble. Same thing as your diabetic medication. You give anti-diabetic, you must check the blood sugar after you do it. You could have overdosed him and his blood sugar be hypoglycemic. That's bad, isn't it? Same thing as antihypertensive. You give medication, you must check after that. Same thing as reversal agent. You give reversal for his muscle paralysis, you must check whether he has adequate muscle recovery. Then only you will extubate the patient. Okay.
Okay, doctor.
All right. Anything else? Mind. Okay, what is going to happen now is I'm going to post to you a first let's stop sharing first. Right. Okay, all right. I've just done a simple 5-minute question SAQ scenario thing, and then you can give it a go and see how you like it. Give me a minute. I just look it up. How do I give me a minute? How do I share this? I think give me a minute, yeah.
All right, doctor.
Okay, if you can look at the chat, there is a link to a Microsoft Forms. Can give you a go. You take you about 5 minutes or so. Manage to open.
Yes, doctor.
Okay, give it a go. See how you do. How do you like it? Something simple. That's how the SAQ would be like. And obviously that won't be the question that's going to come out, is it?
Prof, will we discuss the questions or that's it? Doctor?
Hear you. All right, I've got a, let's see now. Let me just show you the screen. All right, there are 44 responses. Let's look through that. So this basically is how most SAQs will be like. All right, this is a simple thing. Right, they'll give you a scenario. You are called to attend a middle-aged man in the emergency department. You'll refer to the anesthetic in view of his poor respiratory effort. You have been informed that this patient has a complaint of central chest tightness and associated with profuse sweating in 2 hours prior to admission. So why did he come to hospital? What's wrong with him?
Chest tightness or chest
Okay.
pain.
Okay, what's the diagnosis?
Most likely myocardial infarction.
Okay, right. So you find 2 relevant medical histories that you would like to obtain. This sort of a gift question. You can ask anything related to it related to his myocardial infarction. There is hypertension, diabetes, and stuff like that. Everything that you can think of can be there. All right, then you find that the answer could be, and then they say at least 2. That means you get 2 marks here. Okay, for the history that you want to put in. Right. So if you notice, there will be very many answers. Okay, from obviously allergy history, medical not very relevant, hypertension, diabetes, hyperlipidemia, stuff like that, that will help you in this diagnosis and over management of his poor respiratory effort, if you want to think about it. Why does he get a poor respiratory effort with myocardial infarction? Can you guess? Nearly all the answers that you gave here are correct. Okay, any guess why he has got a poor respiratory effort with a myocardial infarction?
Is it because of low cardiac output?
Okay, why did he get a low cardiac output? Probably he has gone into heart failure, isn't it?
Yeah. Yes.
On examining him, you notice his respiratory rate is 35. That means his tachypneic. Sinus, pulse rate 110, and cold and clammy breeze. When you say cold and clammy breeze, what does it mean?
Patient is in shock.
In shock, okay, hypotensive shock. Right, and speaking in 3 word sentence, that means it sounds like this patient has got pulmonary edema. All right, what would you initially manage for him to improve respiratory parameters? He's still breathing. What would you do? Give oxygen, right? Would you want to use at least will be only 1 mark lah. All right, you will probably give oxygen, but you will really not a face mask, but more like a high flow mask, isn't it? If you give a oxygen face mask, they'll probably give you half a mark. Supplementary oxygen, maybe half the marks, right? Mask or intubation, maybe if you want to intubate, all right? Okay, and then you find out the 3rd one, after your initial management, his respiratory parameters did not improve, but he deteriorated. So when you say deteriorating means he has gone from sinus, he has gone worse than that lah. Right? These 2 further management steps. Obviously, you want to start intubating this patient. Okay, and You also will worry about his cardiac performance. So you find that you will try intubate, and also you will resuscitate or give fluids or use inotropes. Okay, in managing this patient. Okay, so you get, since at least 2, that means you get 2 marks. You decided to admit him to intensive care. Probably you have intubated the patient, set 3 criteria for his admission. What would you be? You'll be mechanically ventilated. Right? He needs intensive monitoring for his respiratory failure, and also what else? He had a myocardial infarct, right? So you probably have also management of his to your indication will be heart failure, respiratory failure, and monitoring bodies of any other complications from these 2 things. Okay? Any comments?
Doctor, for the last question,
Mm.
about the criteria for ICU admission, can we write something like along the lines like, patient require intervention that can only be assessed through the ICU, like intervention that the only ICU offers?
Agree. Answer is adequate, but which one are you talking about?
Like
You're talking, you know, like you're saying, is your answer is quite general, isn't it? You want to say, okay, yes, what would be the intervention that the ICU can give specifically for this patient?
Is it like the mechanical intervention, the one, the
Say again, can't hear you, sorry.
is it the one that you showed to us during the ICU, like the PEEP or the stuff, doctor?
No, more like generally speaking, this patient has got organ failure, right?
Yeah.
What organs failed?
Respiratory.
Respiratory. So what is the intervention that the ICU can support or can provide? Respiratory support, right? Agree?
Agree.
So you probably, it's better to say respiratory support or mechanical ventilation rather than say like you mentioned, which is quite general. You're not wrong, but it's the answer will be only half what the examiners are looking for. Okay, the SAQ is a bit more tricky because of that a little bit unknown of what the examiner expects you to answer. Okay, anything else? Any other comments?
For the ICU criteria, can we put the patient can has a high potential to survive?
Then why you want to put him to ICU? Why do you admit him to ICU? What is it that the ICU can do for him? What is it that you want to do to him in ICU? Yes, the whole idea is to make the patient survive lah. Memang lah. Itu why the patient go to hospital anyway. But like I said earlier, your answer is only half correct. It is too general to be how to put it, to know what you are doing lah. It's like saying, right, why you go to University of Savagear? Because I want to graduate lah. Am I right? Not good enough, isn't it?
Yes.
right? So you need to be more say, okay, I want to go university subject because I want to become a doctor, or if you're going to be a pharmacist. That means you're going for specific things. Anything else, everyone? Any other comments? Or can we call it a day?
I think that's all, Doctor.
Okay. Fadli, okay, settle ke?
Thank you very much, Doctor. Yes, Doctor.
All right. So hope for the best. Shouldn't be too difficult. Don't worry about anesthesia, like I said. Okay, then I'll call it a day. Thank you very much. I think thank you for joining the session. Quite a number of you. All right. Hope for the best. See you all next week. Bye. Assalamualaikum. Salam sejahtera.
Assalamu alaikum. Thank you, Doctor.
Thank you, Prof.
Thank you, Doctor.
Prof.
Thank you, Doctor.
Prof.
Doctor.